Nick Majerison here. Welcome to Top Med Talk. And on today's Top Med Talk, we present part 2 of EBPOM 2018 Any Answers? Special programme that was, of course, streamed on Top Med Talk. And if you missed it when it was streamed live, what I want you to do is to stick around. At the end of the podcast, I'll explain to you how you can always be part of our live broadcasts here on Top Med Talk. So make sure you listen to the end of the podcast for details on that. Before that, though, let's dive into part 2 of this special programme, where Monty and Desiree get stuck into a conversation about artificial intelligence. Everyone's talking about it. Everyone's doing it. Or so they say. What's the reality behind these technologies, though? Let's have a listen, shall we?
Top Med Talk. Now, one of the things I brought up in my talk was a relatively recent publication using this automated closed-loop technology. I mean, we increasingly recognise the fact that when it comes to fluid management, many of us can't be trusted. The information on that in epidemiological studies keep coming through, but there's relative, and we'll get the link up in the website, a study where they've looked at closed-loop technology, where they've let the machines help us. And when they did that, there were differences in the volumes of the colloid versus the crystalloid, and the results looked quite a lot better in the colloid group. So maybe we need to let the machines help, and maybe then the differences in the drugs come through.
I don't know.
Are you happy to let the machines help?
I think we've heard, and I think we may play something here in just a little bit, but I think relying on a machine, there's a bit of discomfort that comes with that, or just not comfortable with that. But, I'm open to it. I haven't seen it myself. Have you seen that?
So we're a little bit familiar with it in a way that we may not fully understand. Many of our anaesthetic machines, if we go to low flow, we basically push a button and dial up a MAC, and the computer sorts out the flow rates and does all the adjustment for us. I mean, we don't let the pilots land the planes most of the time this time, so every time you're coming in a difficult landing, it's usually the computer that does it because they're better than the humans. And a lot of the ships are sailing around under the computer, and when the human takes over, they sometimes put it on the rocks, as has happened recently, and we're starting to get to a point whereby we're maybe going to let the computers drive the cars around. Yeah. So is that such a...
No, it's not a bad idea.
Well, I mean, we had we had a wonderful lecture, I think, from Professor Sir Bruce Keogh about the National Health Service on its 70th birthday, and he commented on the future and what the future has to hold for us. Let's have a little listen to that.
The future, in my view, is going to be determined by economics. I've already alluded to the fact no one has money. It's the number one driver of all healthcare systems in the world. The second is that people want more comprehensive and more integrated care. And the things which are going to impact on us, I think that we need to respond to, this is about the Darwinian adaptation, is to mobile technology, artificial intelligence. That's starting to come together. When you have Jeff Bezos saying he's linking up with Warren Buffett at Berkshire Hathaway, and they're linking up with JP Morgan to bring the same kind of disruption to healthcare, we need to sit up and take notice, because that's here now. And then finally, genomics and cell and gene therapy.
So there we have a list of things over the horizon. So cell and gene therapy is here, genomics is happening. Everyone's talking about artificial intelligence and machine learning. Yeah. And I think that's, a while ago the joke used to be that big data is like teenage sex. And now it's artificial intelligence and machine learning is like teenage sex. In other words, everyone's talking about it. Apparently everyone's doing it. But if you talk to somebody, the truth is that certainly very few people are doing it, and certainly no one's doing it very well, is the conclusion on that one. But we have been hearing about some, let's call it AI machine learning developments. Have you seen anything at your end?
I haven't. I mean, I've heard a little bit about some of the things that are on the horizon and new technology that's on the horizon. But I liked what Sir Bruce had to say about having to adapt. Yep. And I think that in anesthesia specifically, we're not always great at that. But I think adaptability is how we need to look at this. Have you seen this new technology? If we
come back to HPI, which I teed up at the beginning, the Hypotension Predictive Index or Hypotension Probability Index. But I think we are increasingly accepting the fact that the machines are going to do a lot more. And I remember Ramani Moonesinghe was in the panel, which you can listen to up online now, following Sir Bruce's lecture, as one of the panellists there. And she made a comment that initially I think jarred a little bit on you. I'll play that to you in a second to remind you, and then we'll discuss it. But I think she thinks the machines are going to take over sooner rather than later.
One thing that we absolutely know is that we will be completely unable to predict the world that the doctors that are going through medical school right now will be living in when they retire. Absolutely unable to do that, because we've seen that in our own working lives so far. And one of the things that we need to breed in this generation of healthcare professionals coming through now is flexibility and the ability to understand that they will not have a job for life necessarily, or it won't be the same job, decade on decade. And they need to be flexible for that. They need to be prepared for that. They need to be resilient for that. In this country, we've had a lot of antipathy to physician extenders, in various parts of practice. Forget nurse anaesthesiologists or whatever you want to call it. It's going to be the machines, because the technology is going to take over the traditional role, for example, of the anaesthetist and the surgeon and so on and so forth in our, I hope, lifetimes. So breeding that resilience and that flexibility in undergraduates that are going through now is, I think, the key thing that we have to address.
No, I think the bit you heard...
I love Ramani, but did she just say I was obsolete? Or did she just skip over me completely? I don't know. No, not me.
So I think the context here is that you Desiree, is a nurse anaesthesiologist, a non-physician provider of anaesthesia.
Yes.
We're in a complicated place in the UK, whereas we're coming to terms with the fact that the workforce required to deliver anaesthesia in the future is going to include non-physician providers of anaesthesia. That seems pretty clear cut now. So I think what she's saying is, in analysing the threats. Don't be worried about the non-physician anaesthesia providers. The machines are going to come to do it, and the machines.
And we're all going to be obsolete.
We're going to be doing different. The cars will be parking themselves.
Yeah.
The planes will still be landed by the computer. The boats will still be done by it, and some basic, provision of anaesthesia surgery will almost definitely be done by the machines. Mm-hmm. So. You touched on the fact that things are starting to get interesting there. Mm-hmm. I mean, in Sir Bruce's talk, he emphasised the fact that one of the challenges in AI, machine learning, it means different things to different people, it covers a spectrum, is that the use of complex data and computerisation to provide decision support is in a complex area for approval purposes. Mm-hmm. Is it an indicator that things might be happening? Is it decision support? Or do we let it go all the way to closed loops where the machine says, I think the physiology is becoming perturbed. It talks to the syringe driver and it starts to give the drugs. Now, we've made, certainly in our world, I think we've made one of the first big steps, and that's with this HPI. How much have you heard about Now, it's called different thing in Europe and a different thing in the USA. Yeah. But it's about the prediction of the likelihood of developing hypotension perioperatively. Have you heard? Yeah. Have you seen that yet?
I haven't seen it. I think it just got FDA approval in the US. Is that correct? Yeah. So we're just getting into that discussion about having the HPI discussion and utilization in the OR. I know that it's coming soon. It's here, though, right?
It's here. Been here in Europe now for a while. Uh-huh. So it's from Edwards Life Sciences, one of our industry partners, one of our sponsors. Yeah. And it was approved in Europe some time ago now. So there's been a European collective of people who've been trying to come to terms as to what it has to offer and evaluating it, etc. Mm-hmm. And literally just approved by the FDA in the last few weeks. Called Hypotension Predictive Index, I think, in the USA, and Hypotension Probability Indicator in Europe. But whatever it is, it's the fact that using Edwards technology, arterial waveforms have been acquired and patterns of arterial waveform changes have been analysed in big computers with clever people to turn around and say, can we learn from the signal the likelihood that a patient undergoing, for example, anaesthesia for major surgery, is going to have a drop in blood pressure soon in a way that can't be spotted by clever doctors, nurses, etc. Now, I struggle with that concept because I think that if I'm paying close attention, it's not going to happen. What are your? I mean,
I agree. I feel the same way. Don't really want a machine telling me if I'm keeping close eye on all my parameters. But I know that not everyone is like that. We know that there's a lot of variability. So
now, what if the machine's better? Do you use any driving?
I could never.
Do you use any driving apps? Do you accept the weather apps? If it says there's a 70% chance of raining, do you bring an umbrella?
Yeah, and I always use Google Maps, even though I know how to get there, to tell me what the traffic pattern is.
Exactly. So so some of our colleagues from the Royal Free Hospital have been using the technology for a while now, and one of the fantastic lunchtime sessions, which included a great explanation of how HPI was developed, we heard from Dr. Spiro and one of his colleagues from the Royal Free Hospital talking about the hypotension probability indicator, as it's called, I think, in Europe, and here's his view on it.
We're going to talk today about HPI in clinical practice. We heard pretty clearly from Monty that there's plenty of evidence out there that single episodes of hypotension are associated with adverse events. And we're lucky at the Royal Free in that the flow track is our current departmental standard for major hepatobiliary surgery. And so when we were asked to trial this upgraded software, it seemed like quite an exciting opportunity, even though I have to say I was extremely sceptical. I was told that this device would give us 5 to 15 minutes of warning before a hypotensive event, and I thought, given that in the major HBB patients we've got a complex patient having complex surgery and a variable anaesthetist in myself. How can a machine predict something that we can't see when looking at an arterial line? Anyway, I played with it a little bit in theatre, and I have to say it made me quite uncomfortable the first time I used it. I had a beautiful screen, beautiful chart, yet I was still being told the patient's chance of hypotension was 90%. And it made me very anxious, and I couldn't play with my iPhone quite as much as normal. And yet, when it told me that the hypotension was coming, even though my art line looked lovely and I couldn't see much swing and everything else, it did actually happen, and that made me feel even more uncomfortable in my clinical ability.
So
I love his honesty.
Yeah, it's honestly, and he's a very high caliber anaesthesia provider.
Yeah,
and I think he genuinely shocked, as I think many of us have been who've been exposed to this now. I think if we look at the weather app idea, it's, you get up in the morning, you open the doors, you look out, and it's bright sunshine, and it says there's a 90% chance it's going to be raining at 4 o'clock. You used to think, I don't know. I kind of think, I've got a feeling in my bones that's not going to happen. So this is quite a paradigm shift for us.
A game changer, really.
Now, we've got to learn how to use it and use it well.
And there's always a learning curve.
There will be a learning curve. We've got to understand it's not a physiological variable, so we mustn't start treating it.
Yeah.
It's a warning. It's a telling you the likelihood that hypotension is going to happen. So that's a lot of adaptation that we have to make. And the secondary screens that come with it are suggestions as to what are the likely things that are perturbed that are likely to cause the hypotension. Is it preload, afterload, contractility? So lots of extra cool stuff coming along with that. But mixed in with all of that, we kind of think, my prejudice to start with was, well, I am a goal director. When I'm in the operating room, I would be a goal director. Okay, so I would turn around and say, I'm managing stroke volume. If I thought there was continuous need for afterload, preload adjustment, I'd be running vasoactive drugs. So if I'm all over that like a cheap raincoat, like a rash, then hypotension's just not going to happen.
Yeah.
Is that your feeling?
It is. I mean, that's the way that's the way I think about it too. But I know that there still aren't a lot of goal-directed people out there. So it's just, for me, it's another tool in the toolbox. But I mean, what is the value add of?
Well, I mean, that was the next big question. So we had a question from one of our great supporters in the crowd who asked a number of fantastic questions. But he came forward with this one, which I think was really challenging. In other words, if I'm managing all these things actively, surely it's not going to happen.
I'm not very much convinced yet how it will add something. If I am keeping a very close eye along the operation on the parameters, and I'm correcting everything as I go along the line.
So I absolutely see where you're coming with that, because my original prejudice was if you're a very proactive hemodynamic manager,
Exactly.
then those events should never happen. But I have seen presented by Thomas Sheeran, for example, very compelling data to say you might think that, okay, but actually that isn't necessarily what happens. Is that right?
It's exactly my experience. So
Excellent.
What you were saying is exactly what I said to Ed Hembrow when he came to speak to me about it a year ago.
Fantastic.
And I said, I'm a self-confessed physiology geek. Okay, I love looking at arterial lines, and I think I'm good at it.
And I'm really good, yeah.
I think.
Yeah.
But
There might be someone better, but, you know.
even on this stage. But it definitely gives you something that you can't see with your eye and you can't see with the normal trends we look at. I'm not saying it's perfect in any way, but it definitely adds something.
So really interesting. I think watch this space. There's a lot to learn about it. I've been lucky enough to be exposed to the technology in a highly controlled laboratory environment, and it's very exciting. I think as you'll get to the stage as well where you mix in more physiological variables, and then I think as we get more confident in connecting the indicators to the therapeutic interventions, and we're seeing that with fluids, we're seeing some early work with that with the hemodynamic, with the cardioactive agents, and I think of it increasingly more like if you're using a sailboat and you want to make a cup of coffee while you're sailing off a particular direction, you hit the autopilot.
Hit the button.
You're not letting the autopilot completely take over the journey. You're just saying, could you hold this course while I get on and do something else? So that's exciting times.
Top Med Talk.
The rest of the programme will follow here on this podcast feed, topmedtalk.com. Now, if you missed out on that live show, here's why. You're obviously not part of our mailing list. It doesn't cost you any money. You can go to the website now and sign up, www.topmedtalk.com. Sign up to the mailing list, give us your email address, and we will make sure that we send you an alert whenever it's the case that Top Med Talk is going to go live. That way you can interact with the programme and be part of Top Med Talk in a way that perhaps you haven't been just yet. Loads of people have signed up to our mailing list already. A good half of the audience, we estimate, are part of the mailing list. But what about the other half? That's you. Go and sign up and do it as quickly as you can. Topmedtalk.com doesn't cost you any money at all. It's free. It's proper free. All right. The only thing it'll cost you is a little bit of time, maybe 2 minutes to do. And we'd really appreciate it if you could do that. Topmedtalk.com. Don't forget, of course, you can meet the Top Med Talk team. All you need to do is turn up to one of our events. ebpom.org/meetings is the place where you can find out details of that. That's ebpom.org/meetings. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September. ebpom.org for more details. That's ebpom.org.